And we're online now, right?
Yes.
Yes, okay. So welcome everybody. I'm Robert Klitzman. I direct the Masters of Bioethics program here, and we're delighted to have you all with us. And we also have around 25 people or so plus online who are watching this simultaneously. And for people online, during the questions and answers, please feel free to send questions as well. And we will address your questions as well as the questions of people in the room. So without further ado, I'm thrilled to welcome Dr. Kenneth Prager. Dr. Prager is the chair of the ethics committee here at New York Presbyterian Hospital uptown. He has been one of the nation's leaders in areas of clinical ethics and ethics consultation for several years. He's a pulmonologist. He trained at Harvard. He's been here for many years, and he has taught medical students and house staff. He's taught in our Masters of Bioethics program. He's lectured all over the world. He's written textbooks, articles. He has a wonderful article on clinical ethics consultation in the most recent volume of the Journal of Clinical Ethics that I commend to your attention. And we are thrilled to have him with us. So without further ado, please join me in welcoming Dr. Prager.
Thank you very much, Bob, for that nice introduction. First, I want to wish you all a hearty appetite while I'm working hard here and you're enjoying your food. So today I'm going to talk about a case that, an actual case that we had at the Ethics Committee a few years ago. I have changed some of the details about the patient in order to preserve as best possible confidentiality. And this is a uniquely interesting and challenging case, as you'll see. It raises many interesting questions, and I'm going to ask you folks to put on the shoes of an ethics consultant. After I present you with the details of the case, I'm going to ask you what you would do if you were chairman of the ethics committee or a member of the ethics committee, and then I'll tell you what the right answer is. There's actually no right answer, I'm kidding, but I'll tell you what our approach was, and as you will see, there is no right answer because there was actually differences of opinion in ethics committees in two different institutions. So I'm going to speak about ethical issues involved in turning off a pacemaker. Yeah, till all the noise dies down. It's all right. Okay, great. I'm going to speak to you about ethical issues in turning off a pacemaker. And just for those of you who may not know, a pacemaker is a mechanical device which is implanted inside the body. And it basically consists of a battery, which is in the chest wall, and wires that lead from the battery into the heart. And these, the battery sends off pulses, electronic pulses, which cause the heart to contract. Who gets a pacemaker? People who need a pacemaker are people whose hearts are not working correctly electronically. In other words, their heartbeat may be too slow, or they may have periods when their heart stops beating. The muscle may be fine, but the electric system is not working. So the pacemaker can be a life-saving device, and there are hundreds of thousands of people who have this. This is the case of Mr. J, and this was a unique request by Mr. J to turn off his pacemaker and to allow him to die. I want to acknowledge the fact that Dr. Blinderman, who is who's the head of our palliative care service, some of these slides I have taken from him because this is a case that we presented jointly at Medical Grand Rounds a number of years ago. So I acknowledge Dr. Blinderman's excellent slides. So those of you who have any familiarity with clinical ethics, you probably know the four major principles of clinical ethics. There's patient autonomy. People have the right, when they have capacity and they're adults, to decide what should or should not be done to them. Beneficence. We doctors and nurses and social workers, we want to do good. I just acknowledged you, Craig. You didn't. Yes, I acknowledge you for some of the slides in here. So thank you in person. Beneficence, which is the need to do good. That we are in this profession to help our patients do good. Non-maleficence, first, do no harm. If we can't get somebody well, at least we should not harm them. And finally, justice, which is the just allocation of scarce resources. So what is the ethical justification? I told you now that some patients who rely upon the pacemaker to stay alive, is there any ethical justification for a doctor to comply with a patient's request who says, I no longer want to live, for whatever the reason happens to be, and I ask you, Dr. Prager, to turn off my pacemaker so that I can die in peace? Well, we say that, yes?
Can you, I might have missed it, but how old is the patient?
We're going to get into all that, all the details, yes. I'm just giving you a little preface now. So the basis or the justification for allowing a patient to turn off a pacemaker or to reject any other type of life-sustaining device is the principle I just told you about patient autonomy. People have the right to say, I don't want this anymore. I don't want this machine, I don't want this medicine, and so patients have the right to refuse even life-sustaining treatment. We cannot ethically force somebody who has capacity to accept unwanted medical treatment. When did this start? This started basically legally in 1976 in the United States, when over in New Jersey there was a young woman called Karen Ann Quinlan, who was in her 20s, who took alcohol and barbiturates at a party. She had a cardiac arrest, was resuscitated, and she ended up in what we call a persistent vegetative state. So her cortex was not working. She was unaware of her environment. She was totally comatose, could not respond, but she was breathing and she was making urine. The rest of her body was working. Her parents, who were devout Catholics, after being told that there was no way that their daughter could ever recover, they said, this is undignified. Our daughter would not want to be kept alive on a respirator and a feeding tube. Take off the respirator and allow her to die in peace. The doctors said that's unethical, it's illegal, it's euthanasia, it's murder. We will not do this. The DA said, we may prosecute you if you do this. The hospital said, we will not allow this because of legal jeopardy. And so the family appealed this case, and the case ultimately went to the highest court in New Jersey, and for the first time in American history, a court of law said patients have the right to refuse even life-sustaining treatment, even if it means that the patient will die. This is the right of privacy, the right of autonomy, and so they took Karen Ann Quinlan off the respirator. And guess what? She did not die. She breathed on her own. The pulmonologists then obviously were not as sophisticated as today, and we didn't have the machinery of today. I'm a pulmonologist, I might say, and they could not predict that she would breathe on her own, but she did. So what do you do then? She's alive. What's keeping her alive at that point? Her feeding tube. She's unable to eat. She's lying in bed. The parents felt that it would be unethical to remove the feeding tube, whereas they felt it was ethical to remove the ventilator. They felt that depriving their daughter of artificial nutrition and hydration was unethical. And she lived for another 9 years before she died of inanition and pneumonia. A tragic situation. You can imagine how the parents must have suffered during that time. But for our purposes, it established for the first time in American history, patients with autonomy can say, no, let me die, stop X, Y, and Z. Now, is that assisted suicide? Is that euthanasia? If I were the doctor to turn off the respirator and the patient were to die right then, would I be guilty of killing the patient? The answer is no. Why? Because my intent in turning off the ventilator is not to kill the patient. It is to remove an unwanted type of treatment that the patient does not want. If the patient, and this is a perfect example, the Quinlan case, when the doctors turned off the ventilator, their intent was not to kill her. Their intent was to comply with her wishes, not to be kept alive with the ventilator, and guess what? They were surprised. She didn't die. They didn't euthanize her then. They didn't inject her with an overdose of morphine. So it shows you that removing an unwanted treatment, sometimes it does not lead to death immediately. So the intent in removing these devices is not directly to cause death. The intent is to remove an impediment to a peaceful death. It is an intent to remove an unwanted treatment. The patient then dies from what? They die from their underlying illness and not from the actual act of the physician to kill. Okay. Now, is a pacemaker different than a respirator? A respirator, of course, is a machine that blows air into a person's lungs through a tube that is inserted in their mouth or nose and that goes into their windpipe. So is turning off the respirator is turning off the pacemaker the same as turning off a ventilator? They're both devices that may be life prolonging. They're both artificial devices. Now some people say that, it is different, because when we put the pacemaker into somebody, it's entirely in their body, and it sort of becomes incorporated as part of their body. It's almost a little bit like a transplant, like we transplant the heart or we transplant the kidney. And so turning that off has greater ethical is wrong. Whereas a ventilator is entirely external to the patient. It's the tube that goes in their chest and so forth. And so some people feel that there is a difference between the two. However, most people feel that that really it is just as artificial as the ventilator. Just because the location of it inside the body does not alter the ethical equation of turning it off. After all, I can adjust the pacemaker outside with a magnet and turn it higher, make it beat faster, make it beat slower, just as I can with a ventilator. So the mere fact of the internal presence of the pacemaker, most people feel, does not alter its ethical status, shall we say, as an artificial machine that is keeping the patient alive. Once a kidney is implanted, we don't have control over the kidney. We don't have dials that we can turn the kidney up or down. It becomes part of the patient's body, just as their own kidney. So there is a difference. Then the other issue is, what about not turning off the pacemaker? What happens when the battery dies or starts to die? And we choose, with the patient's wish, not to replace the battery. So the patient therefore dies not from an overt act of committing, but from withholding something, from not putting the battery in. And some physicians may feel more comfortable in not putting in a dying pacemaker at the request of the patient rather than turning off the pacemaker. I'm just giving you these different ways of looking at at how people actually look at these different devices. Now, here we go to the case. So this was, and I mentioned before, I've changed some of the details here. This was an 82-year-old man who presented to my office, and he asked me to turn off his cardiac pacemaker so that he should be allowed to die. Walked into the office looking as healthy as you and me, walked in, that's what he wished, with two of his children. Now this patient, the history of this patient is that he had had a pacemaker implanted a few years ago. Why? Because he was functioning quite well, but he then developed a very rapid heart rate. And this heart rate was so rapid that it caused heart failure. And the doctors could not control his heart rate with medicine. So what they did was they actually did an invasive procedure where they destroyed one of the key elements of the electrical conducting system of the heart. They just electrocuted it. They burned it out. And it made it impossible for the heart then to beat rapidly, but it also meant that the heart would beat too slow to sustain life. So as a result of doing what we call the ablation, the patient required then a pacemaker to cause the heart to contract. So, but the reason that this was done is that if we hadn't done this, the patient would have died of heart failure because of an uncontrolled rapid heart rate. So we did a destructive act, replaced it with a pacemaker, and that meant that this patient, this man, was totally dependent on the pacemaker for life. Over the next few months, after the pacemaker was put in, he started to notice that his memory was declining. And he had been living alone. He was a widower. He was quite functional. But because of his memory problem, he saw a neurologist. Other than his cardiac history, the only other relevant fact is that he had had prostate cancer, which was resected years before, and he had no evidence of recurrence. So he was basically healthy, but he was dependent on the pacemaker, and now noticed that his memory was going. So the neurologist did a complete evaluation, and they did blood tests which were unremarkable. They did a spinal tap where they put a needle into the epidural space. They take fluid out called cerebrospinal fluid. They analyzed it, and it showed that the protein in that fluid was abnormally high, and he had a protein called the tau protein, T-A-U, and this is seen in people who are likely to develop Alzheimer's disease. He had a CT of his head, which showed a little shrinkage of the brain tissue, which was not uncommon in people who are 82, no stroke. So the assessment was that he had an encephalopathy, which is basically pathology of the brain. They weren't quite sure of the etiology, but they strongly suspected that he had early Alzheimer's disease. And in fact, he was beginning to lose his memory and have difficulty with functioning. He lived alone, he was very independent. He had previously been independent of all his activities of daily living, and according to his son, the patient now had limited functioning. He was finding it harder to live alone in the apartment. He'd forget things and so forth. He had 2 adult children. One of them was a son who had an anxiety disorder, very severe, did not work, and he had been estranged from his father for years. So he was not very much involved with his father, but did come along into my office with his father. Then another son had a history of depression, but he was high functioning, and he lived in another city, but he would visit his father about 2 times a year. Of note, the patient's wife died of Alzheimer's dementia 10 years before, and he had cared for his wife for the last years of his life. He knew what Alzheimer's was better than anyone. He had been there, done that, seen that. He was a religious person. He was a religious Catholic, but really had no religious affiliation right now, and religion was not an important part of his life. So I'm asking you, should I have referred him to the cardiologist to turn off the pacemaker? Here's an 82-year-old man. He knows the path that he's going down, but it could take years for him to die. He was not imminently dying. He had seen his wife go through this process for many years. He had taken care of her. The pacemaker was keeping him alive, and he basically said, I've lived my life, had a good life, wasn't that close to his kids, really didn't have all that much to live for, and he did not want to go down the route of Alzheimer's. And he said, you, Dr. Prager, have the obligation to turn off the pacemaker. I know what is involved. I have the right not to be kept alive by this device. What should you do? What should you do? What do you think about that?
Who would say turn off the pacemaker?
All right, yeah, why don't we just take a vote right off the top and see, all right, who thinks we should turn off the pacemaker? So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Who says we shouldn't turn off the pacemaker? 1, 2, 3, 4, 5, no cheating, those who know the case. 6, 7, 8, 9, 10. So the turning offs have it. The plurality, we live in a democracy, so I should have just gone, referred him to the cardiologist. He's got autonomy, has capacity, just turn it off. Okay. Those who feel well, why don't we hear a representative or representatives from both sides? Those who feel that we should turn it off, who would like to speak in favor of that? Yes.
Hi, Donna Field, Northwell Health.
Yeah.
Bioethics. I had a case similar to this.
Okay.
And we turned it off because he had the capacity and ability to create his own advanced directives and his own goals of care. He knew that the progression of his dementia, it was a she actually, the progression of her dementia was going to come to a point where she was not going to be able to have her own control and she wanted her own control. So we said, yes, here is your advanced directives, here's your MOLST, here is the goals of care, and we turned it off. She didn't die because the pacemaker, she wasn't ablated.
She didn't die.
She didn't die because she wasn't ablated.
Oh, she did die.
No, she died about a year later.
A year later.
From the advanced dementia.
Ah,
Oh,
well,
wow.
that's interesting. So
She
the
did not
turning
die
off the
because she didn't have an
pacemaker.
ablation. The AV node in her was not ablated.
Yeah, she did not have an ablation.
Right.
Yeah,
Whereas
so,
you said
so
he
the
was.
turning off the pacemaker in your case was not so clear cut
Correct.
as in this case. And like, okay, so that, thank you for being, how advanced was her dementia, that lady?
She was still able to make her own decisions. She had moments of forgetfulness,
Uh-huh.
but she
Was
had
she
had
living
the same.
alone?
She was living alone.
She
yeah.
was.
And she was opting for assisted living and going into
Okay,
dementia.
and she lived one more year and died, you say, of her dementia, not
She
a cardiac
died
death.
of actually pneumonia.
Of pneumonia.
Of pneumonia.
Okay.
Because she wasn't moving around as much
Okay.
as she had been.
Would you have turned it off, do you think, if you knew for a fact she would die within a day or two? Would you have still done that?
It's still a goals of care. I would have brought palliative in to have conversations. I
And if
wouldn't-
palliative said, one guy from palliative said, turn it off, the other said, don't turn it off.
Oh, really?
Yeah,
That's
no, I'm asking you if that's what happened.
Oh.
It's in your lap.
So what I would do is set up definitely set up some sort of a multidiscipline goals of care conversation to hear what he has to say and why. Because just because he wants to die doesn't mean we should allow him to die, but I'm sure he has an underlying reason. And in this particular case,
Okay.
having this dementia, he wants to maintain control of his death.
So you're introducing a new element. You're saying just because he wants to die doesn't mean we should automatically knee-jerk say, okay.
Correct.
Okay. A person who was against turning off the patient, who would like to articulate your reason for not turning it off? Yes, sir.
I have a question.
Yes.
So, has it been determined that the patient has any suicidal ideation or?
Okay, so you're asking, so what would you recommend to see if he had suicidal ideation?
Well, I think at least having psychiatry come and talk to the patient
Okay.
and determine whether he's having active suicidal ideation is important in the workup before even asking this question. Because if he does, I mean, I think it's clear based on what you said, especially with this distinction that.
By the way, the microphone's not working.
Oh, it's not?
Yeah.
Okay.
What?
For the screen, I believe.
Oh, it's
Oh,
for
okay.
there.
So
if we don't hear him, it's okay. I see.
just, I'll talk
Speak
louder,
up
sorry.
louder.
I thought it was working.
Okay.
This would clearly cause his death in this
Yes,
case versus
yes,
that case
because
where
of the
it wouldn't.
ablation,
Yeah,
yes.
and he's aware of that based on what you
Yes,
said.
well, that's what he wants.
So right. So does he have capacity to make this decision
Okay.
if he's currently actively majorly depressed?
So would you say that you would refer him first to a psychiatrist?
Yes.
For an evaluation, does he have capacity? Does he have suicidal ideation? Let's say the psychiatrist said, I think he has capacity. He didn't want to commit suicide, but he found out about his Alzheimer's and now doesn't want to go that way.
Right.
What would you say? Would you vote to turn it off or not?
That makes it, I think, easier to turn it off. But I don't know if I personally would be okay with turning it off.
Ah, so you're taking the chicken out.
Yeah.
Yeah, I see. So let Prager turn it off.
Yeah,
I don't
let
want
Prager
to,
turn it
but
off.
you should do it, Dr. Prager, but I don't want to have any part of this.
Yeah.
I see. Why wouldn't you have any part of this? Why would you not want to do that?
I mean, it's the same as me administering a drug that would directly kill a patient, like potassium or something. I think it's similar to that, and I think it goes against my ethical code.
Okay, do you believe in removing life support across the board? You would never remove life support?
No, I do believe in removal of life support.
You do,
Yes.
but this is different.
Yes, I think so.
And it's different because of? You don't mind me grilling you.
No, not at all. I think it's
I'm
different.
enjoying this, by the way.
It is a form of life support, I guess. Yeah, but it's also it was an intervention that caused this, and we fixed it. So, like, if he didn't have this underlying problem,
Yeah.
we caused this problem for him in some ways
With the ablation.
with the ablation,
Yeah.
and we made him basically like a normal heart, with the exception of this pacing. Then
So
yeah.
Dr. Sticks, the reason I'm doing this is
Yeah.
because you're bringing up all very important points.
Yeah.
And frankly, we all thought about these things, obviously. So everything you said is totally relevant. And I like the fact that you seemed to demur when it came to actually doing it, because something in your gut said, I don't feel right doing this, basically. And maybe you couldn't articulate every reason or write a paper about it, but you would not be comfortable in doing it. Does anybody else from either team want to speak up before we go ahead? Yes.
I just have one question, and I'll say
Yes.
one thing. Does the fact that we actually produced the problem by ablating his AV node, does that make any difference in terms of our feeling of responsibility for
what do
him?
you think?
Because with his tachycardia, I think we could have given him a lot of digitalis or something else.
He failed medical treatment. No,
did, okay.
He did. This was the only way. He would have died without the ablation. He clearly was in bad heart
Okay,
failure.
so, but
But we
I'm just,
did do this but we did it as a life-preserving intervention.
Right. I'm just questioning whether the fact that we induced that issue that he required the
Yes.
pacemaker would make any difference in terms of our feeling of responsibility for his
Okay.
life.
And-
And my other belief is that he's still pretty functional,
Yes.
which is one of the reasons I wouldn't stop the pacemaker, turn the pacemaker off. But if he has capacity, he could now do an advanced directive that would be able to state when he gets to the point that he is unable to live alone, he is a hazard in his home in terms of breaking a hip, starting a fire because he can't use the stove. At that point, he can be reevaluated, and that at that point, if he wants his pacemaker taken off, he will make those statements when he doesn't have capacity.
And would you feel comfortable at that point in turning it off if you were his physician?
I think if he made the decision with an advanced directive when he
Yeah.
was capable of making the decision, when he was in his right mind to
Right.
do it, and was truly, he described what state he would be in such that he was non-functional living at home, that could then be the future plan.
And you would then feel more comfortable, you would do it then?
Right, if he was not
Okay,
functional.
so what
then.
you're saying to him is, I'm sorry, sir, you're not bad enough, your Alzheimer's is not bad enough for me to ethically find it acceptable to turn it off now. I have to wait till you get worse. That's what you're saying.
The way, yeah, I know.
I mean,
I
I'm
think the way I'm
phrasing it
saying
in a
I
way to
think it
make you
sounds better for
uncomfortable,
him,
but that's what you're saying, and I'm not saying you're wrong, I'm just want to make it clear. As far as us having done that, does that also give you pause for, does that alter the ethical equation? The fact that we did the ablation made him pacemaker dependent, and therefore what? That would make it more likely that we should or should not turn it off?
Well, what I was asking you was whether we had more responsibility
Well,
for
I'm
having
asking you
induced the
that.
problem.
I don't have to answer any questions. You guys are in the driver's
Well,
seat.
that's why it's a dilemma.
Okay. All right. Dr. Blinderman, do you want to say something?
Unless other people have comments.
Don't give away anything.
I'm not giving away
please.
anything,
Okay.
and I just wanted to point out maybe another dimension to consider, because
Speak up a little louder.
I'm sorry, just to consider another dimension of the case. What if this turned out to be some mild cognitive impairment as a result of the procedure, namely the pacemaker and the ablation procedure? We do know there is some empiric evidence that individuals who undergo minimally invasive cardiac procedures of all types, there is a percentage of those who will then have some degree of delirium as defined, or what we call encephalopathy. And so, what if it was the case that we sort of triggered this on some level, or just as a complication, and in the workup found that the patient had this elevated tau protein, which gives rise to a theoretical risk of developing dementia, Alzheimer's dementia in the future. Had we not, or had this person never developed any sort of cognitive impairments, there would have been no workup and no notion, right, of this impending future that he would find unacceptable. And so I wonder how might we consider the sort of the sense of what does it matter, in other words, that there is this looming Alzheimer's dementia of a certain degree of certainty, right, versus someone who finds their current status unacceptable.
Now, does anybody want to say, before I go ahead with more information and more stuff, anybody else want to comment? Yes.
I had a question.
Yes.
I don't know if you mentioned it already, but how long did he have the pacemaker? How long did he have the
Yeah.
pacemaker before he decided he wanted to stop?
I would say he had the pacemaker for about a year before.
Okay, and he
about a
was
year.
having a normal quality of life until then?
During that time, yes.
Yes, okay.
Yes, yes. Any other questions or comments? Yes.
My question is like this is not something you can do in your office.
I'm sorry?
This is not something that can be done in the
No,
office.
no, of course
So
not.
there was a plan beyond, like, he didn't come into the office and expect you to do it there. He wanted someone to go to the home.
Well, what we would have had to do, I can tell you that the children were very impatient. one of the sons actually flew in from another country, from another city, and he wanted this done before he was going to fly back. Let's get this done. Yeah, that's the truth. So what I would have had to do if I were to comply, I must say I was kind of shocked when he asked me, this lady sitting down, but I would have had to refer him. If I were going to do a knee-jerk, you have capacity, autonomy, fine, I'll arrange it, I would have to call up one of the cardiology, electrophysiology people and say, here's the story, she wants it turned off. Now, that doctor might have said, no way, or that doctor might have said, sure, I'll fit her in Monday and we'll take care of it. I don't know. But it would have to be done in a controlled environment, because when you turn off the pacemaker, it's not as if she just goes like that. She may develop a very slow pulse. She may develop difficulty breathing. She may need palliation for shortness of breath. This has to be done in the hospital with physicians in a control so that she doesn't suffer, and nobody will know precisely how long she will live after turning off the pacemaker. Yes. Any other comments before I go on? Okay, so let's go to the next. So we have do we still have that majority in favor of turning off? Did any of you change your mind as a result of some of the comments? No? Still, you changed your mind. From turn off to non-turn off? Okay.
It bugs me that the kids.
Okay. Did anybody else go from turn off to not turn off? So the turn off still have it. Okay. Psychiatric evaluation. Dr. Sticks read that. We did. I sent him. I told the two sons that we can't do this. We at least have to have psychiatric evaluation, et cetera, et cetera. So the cognitive testing showed mild impairments on their mental status evaluation. There was concern for depression. Most people who want to die will have some degree of depression. But the psychiatrist felt that the patient had capacity. The recommendation of the psychiatrist was that we empirically treat the patient for possible depression and reevaluate the patient's desire to hasten death after the treatment of depression. How long would you wait? Wasn't totally clear, but it wasn't going to happen while the son was still here from Chicago. So that was done. Palliative care evaluated. As a matter of fact, Dr. Blinderman did the evaluation. And he felt that there was significant existential distress, this really distress about this person's situation in life, possible depression versus a subclinical delirium, as Dr. Blinderman pointed out. Maybe there was something organic, perhaps a delirium related perhaps to the procedure that had been done. And there was family distress over the patient's mild cognitive impairment and decreased functioning. Yes, the two children were very distressed. So palliative care recommended, let's send the patient to a social worker to see maybe this patient would be happier in an assisted living facility where some of her needs could be taken care of and so on, where some of his needs, and he may feel more comfortable. Freudian. Counseling was offered to the patient. A trial of antidepressant psychostimulant for possible depression, hypoactive delirium, as the psychiatrist said. Review an advanced care plan and living will, go over some of the things about what the future might bring and what the patient may want, and consider, if the patient really wanted to die strongly, consider voluntary stopping eating and drinking, VSD, if the patient maintains a desire to hasten health. I'm not going to force the patient to eat, put a feeding tube in him, and there are patients, this is an accepted measure of people who want to die. They stop eating and drinking. It's not the easiest thing, mostly because of the stopping drinking. People get severely thirsty. Now, we also had a geriatrician involved, and the geriatrician actually made a house call and went to the home of this gentleman, and one of the sons was there, and the geriatrician said that when she went, her bias was that we probably ought to listen to what the patient wants, but when she emerged, she felt differently. She said that this man exhibited some signs of delirium. She felt that the patient did have capacity, and he did not appear to be significantly depressed. And she wrote, "My concern is, who is seeking this? How much influence is his family exerting, especially RE, the urgency? Why are they doing this? I could not determine this at all. In truth, I was ready to say that we consider his or their initial request, but after observing him and his son, I believe that if he wants to end his life, VSED, voluntary stopping eating and drinking, may be the better option." The geriatrician, a very skilled and very experienced person, would not want to turn off the machine. She felt that there may be some influence and some pressure here on the part of the children. And I mean, this is a big deal, obviously. We want all ducks in place. If you're going to go there, you want to be 1,000% sure that this is the right thing to do ethically, etc. So, the so-called right to die, we talk about patients have autonomy and they have the right to die. So what are those prerogatives? Are physicians obligated to respect patients' desires to withdraw life-sustaining treatment in the absence of a terminal condition? Now think about this. I've been practicing medicine for a very long time. Dr. Klitzman was nice to say for a long time. How about 51 years? Okay. Wow, see the eyebrows go up and so on. What'd you say?
I didn't want to say.
You didn't want to, right. And I can tell you that for the first decades, many decades of my career, we removed life support, and remember this goes back to Quinlan 76. Invariably, the patient was dying or near death. This was not somebody who walks into your office and says, turn something off. And so we felt, and we still do, when we remove life support, that the justification for it, when the patient or the family wishes it, is that we are violating non-maleficence by continuing it. We are doing harm. The patient is suffering. We are prolonging the dying process. And therefore, to be beneficent, we should allow this patient to die a peaceful death instead of having them suffer in an ICU with bed sores, et cetera, et cetera. This is a different scenario. This is a different paradigm. This is a patient who comes walking into your office looking as healthy as any one of you sitting over here. Yes, that patient has a potentially lethal condition, her heart, which we did, by the way, cause, but it was caused in order to save his life. But nevertheless, doesn't it give you, or shouldn't it give you a little more pause for thought of turning off a life support when the paradigm is so different, when you have somebody this functional and so forth? So that, I put that in there, and this is a new. And by the way, it's not just here. So now we're seeing this more. For example, patients who have LVADs, left ventricular assist devices. This is like sort of an artificial heart boost. Their heart is there. They didn't get a heart transplant, but the LVAD does keep them alive longer. But there are many people who get terrible complications, and we have had numerous instances now of patients who are not imminently dying on an LVAD machine, but whose quality of life is so poor that they wish to die. Not walking in quite like this and so forth, but the patients are not in, so that creates questions in the minds of the doctors. But who should make that decision? Should the doctor? Does the doctor have the right to say that? And I'll come to that in a moment. So our technology is creating a new paradigm of removal of life support in cases where the patient is not imminently dying. Now, the question in this case, did the patient have autonomous decision-making capacity? It's already been raised by the geriatrician. Was there undue influence here by the children? And also, would you call this a case of assisted suicide in a patient with an ablated AV node requesting deactivation of cardiac patient? Dr. Stix said that he felt that this was almost like assisted suicide because the cause and effect was so proximal. He said it's like injecting the patient with potassium chloride. On the other hand, I could make a case and say, with all due respect, it's not the same. The patient has a mechanical device which is working just like a ventilator, and it's unwanted. It's keeping the patient alive just the way a ventilator is keeping a patient with ALS alive, and we turn it off. We're removing an obstacle, an artificial obstacle to a peaceful death. So I would argue that this is not assisted suicide. Assisted suicide, by the way, technically where it is in 9 states, a doctor prescribes a lethal dose of medicine that the patient then has to ingest himself or herself. The patient commits suicide by taking a doctor prescribed a bunch of medication. So this is not the same, it's not the same thing. Was the criterion of proportionality met? By proportionality, I would mean that you weigh death versus the suffering over here. I'll put it bluntly. Is there enough suffering over here to warrant death that I am part of by turning off? Is the request proportioned to the degree of suffering, of disability? Yes, the patient has existential distress, but it's really more for what's down the road. It's not for this moment. The patient doesn't want to go down that road. Or let me ask you this. If a person, let's say we have another patient with a pacemaker who is 90 years old, and the patient, the only relative this patient has is, let's say, her daughter, and her daughter dies of breast cancer. And the patient comes to me and says, Dr. Prager, I'm 90 years old. My only reason for living was my daughter. She is now dead. I'm 90. My friends are dead. I have arthritis, this, that. I've lived a good life. Turn off my pacemaker. Do we say autonomy, capacity, not particularly depressed. She's had a good life. She doesn't want to go on anymore. It's a convenient way to die, we'll say. It sort of has this machine that we can turn off. I don't have to kill myself and shoot myself. I can have Dr. Prager turn off the pacemaker. But she has fulfilled the capacity and the autonomy requirements. Is this proportionality met? That's the question that I have for you. And again, I'm asking a lot of questions, and it's up for you to think which one way or the other. I told you that I don't have the right. What's that?
Want to take a vote on that one?
Yeah, all right. You want to take a vote? 90-year-old lady, lives alone, daughter just died of breast cancer, nothing left to live for, harder getting around, she's got arthritis, and she's really had it. 90 years old, all of her friends are dead, she lives alone in the apartment, can't get out much, and she wants to go peacefully and not die from pneumonia and so on. Would I, as capacity, obviously has autonomous right, how many of you would accept her wish then? How many of you would turn it off? So we have 1, 2, 3, 4, 5, 6, 7, 8, 9. That's less than 16.
So
Yes.
My answer is a little different.
Yeah.
I would say that she has the right to do that. I'm not a physician, but if I were a physician, I would have trouble actually doing it. But I would still think that she has the right and maybe refer.
Nobody's arguing with the right.
Right.
We don't live in a totalitarian state. She can express her desire.
No, I think she has the
Of course
right
she
to
has the
have it
right.
turned off.
But the question is whether I should accept.
Of
I
course
should
not.
act on what she asks. And what do you feel?
My license doesn't permit me to.
No, you voted to have it done, right?
Yeah.
Okay.
Yeah.
Any other comments on that? Yeah.
If she were suffering, I would. So when folks are going through the procedure of
Yeah.
cutting and then adding the pacemaker, are they in any way explained that from that moment on, that machine will become a part of their body in the same way that their hand is there or their leg is there? Because I think that would take a change to me if they were explained it in that way. Because then, of course, no one can come to you and say, can you just cut off my hand? I just feel like not
So
having-
you are of the opinion that I mentioned earlier on, you feel that it's not like a ventilator. This is really more like a part of your
So
body?
I was in favor of cutting it off, and that's why I'm asking. I was in favor of letting him go if he decided, of course.
You wouldn't let him go, you would turn it off.
Yeah,
It's not letting him go.
I know.
Okay, let's be
Assuming
clear.
that there's no family
Yeah.
pressure, blah, blah, blah. But the question that came to me after that is
Okay.
that with today's technology, we have all these opportunities, for example, to give medications through the body. But then you cannot really promise anyone, hey, if you don't feel like having it after swallowing it, then we're going to have to track down your body and open it in order to take it out. Like the drugs that go through the body, these little machines.
Yeah, well,
So I'm just kind of thinking what's been
I
told.
think you do bring up an important point. What is told to the patients
Yes.
before the pacemaker is put in? And I think in general, what the doctors do say, and I can't speak for all doctors, they explain to them physically, part of your body, et cetera, and I think many of them do say, perhaps not all, that there may come a time when, because of illness or some other issue, that you would want to have it turned off, and we would consider that. I don't know if the doctor says, I'll listen to whatever you say, but I frankly, if I were I wouldn't say whatever you say goes. I would say that in appropriate circumstances, when there is a consensus that this is a request that should be answered, we will turn off. Now, somebody may say, well, you have no right to do that. But look, I have a right. I do have a right as an independent human being who has to do this. I can assert my right of, I don't think this is ethical. So, but I do think that is mentioned to the patient. So that is an important point. So So patients have the legal right, we talked about, to discontinue any and all medical treatments regardless of whether they have a terminal condition, even if the discontinuation of the treatment hastens death. So they have that legal right. It was expressed at the time of Karen Ann Quinlan. They have a right to discontinue treatments even that are life-supporting, even if this hastens death. But again, when I say they have the right, it's like you said, Fran, they have the right to request this. But under certain circumstances, physicians may feel uncomfortable or that it's unethical to grant their request. So whereas somebody, can make, like the case of the 90-year-old lady, I think there are many doctors who would not do that. You see, even though she has the right to say, I don't want this anymore. Now, in 41 states, patients do not have the right to request assistance in hastening death. By that I mean physician-assisted suicide. The number of states that have legalized it now is up to 9. I can guarantee you the number will continue to increase. But again, I hope you will keep in your mind the difference between removing unwanted life support and prescribing something with the intent of the patient killing themselves. Or even in Canada, euthanasia is legal, where the patient with capacity, terminal illness, they have the right to have a doctor inject them with a drug to kill them. It's really killing them, euthanasia, not the patient taking their own drug. Now, suffering in the absence of a terminal condition, physician responsibility and clinical judgment. So we're talking about here, what is an acceptable quality of life and who decides? So there are many people, and frankly, most people who come down with the diagnosis of Alzheimer's disease don't want to commit suicide. Most don't. There may be some who do. They consider their quality of life right now okay. I'm afraid of what's going to happen. I think it's awful, but that may be a couple of years down the pike. Right now, my quality of life is okay. This woman felt the existential suffering that this is causing me, my quality of life is terrible. And so when a patient asks a doctor to remove life support, and I'm not talking about somebody, again, dying in the ICU. I'm talking about the new paradigm of the patient who is not imminently dying and may be on an LVAD or a pacemaker. That's the beginning of a conversation. It's not a knee-jerk thing. You have capacity, you have this disease, turn it off. We have to perform a systemic assessment of the sources of suffering. And we have to explore options for ameliorating and preventing suffering and future outcomes the patient would find unacceptable. That's an ethical obligation, I think. An ethical obligation of a physician who hears from a patient, I've had it, let me die, turn off the machine. We have an ethical obligation to say why, to explore the sources. Are any of them treatable? Is there something that I can do to ameliorate that would make you change your mind? If we don't do that, then we have failed. And one of the reasons people are against assisted suicide, frankly, in the states where it's legal, is that many critics feel that this in-depth analysis of the request to die is not carried out well enough, that there is not, that it's done more, you fulfill the criteria, etc., the repeated request and so on, we'll go ahead and do it. This takes time. And what irritated the sons of this man is that we weren't going to do this right away. And we felt you need to have palliative care, psychiatry, social work, and a time, let the dust settle, let's take a look at this. In most cases, request for a hastened death suggests some underlying existential distress, poorly controlled symptoms, or mood disorder. To give you an obvious example, if somebody wants to die because they have uncontrolled pain, we have pain experts. We have to try to see, is there a way we can address this pain so that the patient may change their mind? Or a mood disorder, for example. Autonomy. So we say the patient must act intentionally with understanding, without controlling influences that determine their action so that it's voluntary. In this case, there was a question. There was a red flag raised as to whether or not this was entirely voluntary. And was this an example of undue influence? It certainly raised the issue regarding the influence of the sons on the patient's decision-making. The fact that the family was so adamant about deactivating the pacemaker and seeking to hasten death in such an urgent made us concerned. It's very rare. Usually when the kids come in, they're trying to talk mom and dad out of it, not doctor, go for it. Let's get this done. I got to get back to work in Chicago. So that's what it was. That's literally what it was. Now, is this a case of physician-assisted suicide, withdrawing a pacemaker? So I think I addressed that. No, I don't think it's assisted suicide. It is removal of an unwanted technological impediment to dying. The patient dies of her underlying cardiac disease. The real question is whether removing the life-sustaining device is ethical or not. That's the real question, not that this is physician-assisted suicide. Is this the same as removing a ventilator in a person with ALS who can no longer breathe, who can't stand their quality of life, quadriplegic, lying there in a bed on a ventilator? Now, the question that was raised earlier, does ablation of the AV node make difference when considering withdrawal of the pacemaker, the question that you asked. If we now think about it, if we confronted this patient prior to the node ablation with a pacemaker and he refused to consent to the procedure, we wouldn't force him to take the pacemaker and we could not control his heart rate, so he would have died at that point. He would have been allowed to die from his underlying disease. Now, obviously, there's a big difference between me turning off a pacemaker and forcing a patient to have a pacemaker. Nobody would argue that we would force this patient at that time. If this patient at that time had said, I don't want this, if he had known about his Alzheimer's disease and said, I don't want to go down this route, nobody would have, that would have been totally unethical. So there's a big difference between forcing a treatment on a patient and removing unwanted treatment when we are the proximate cause of that patient's death. Interestingly, there was a consensus statement in an article in 2010 in the journal Heart Rhythm, which says ethically, cardiac implanted electrical device deactivation is neither physician-assisted suicide nor euthanasia. When carrying out a patient's request for withdrawal of life-sustaining treatment that a patient perceives as unwanted, the clinician's intent is to discontinue the unwanted treatment and allow the patient to die naturally of the underlying disease, not to terminate the patient's life. The Sun actually told me about this article and came equipped and said, you have an ethical obligation to do this, and here's the article. Now, this statement over here, yes, I would agree with this statement, but I would say that there's also a footnote to this statement and saying that there has to be the appropriate clinical setting for the device to be turned off. It's not just, you have carte blanche. Whenever you want it turned off, fine, I'm here to do it. Obviously, there's got to be because of the stakes involved. So yes, that's true, but the but is not there, but the but is a capital B-U-T. Would this patient die of the underlying disease at the pacemaker? Interestingly, the reason that the patient would have wanted to die here was not because of the cardiac disease. So we're, in effect, letting the patient die of the cardiac disease, but the thing that's prompting it is not the cardiac disease, it's the anticipation of the Alzheimer's dementia, which again, I think further complicates it.
And also, if I could
Yes.
just one other thing, just to, you can go back to the slide for a second, where it says the patient perceives as unwanted. And that's a very loose definition of what was going on in this case, namely that it's not that the pacemaker was so troublesome to the patient or causing him symptoms or pain or discomfort in any way, where we might expect that with someone on a ventilator, right? We can obviously see the burdensomeness of the therapy. In fact, when we think about surrogate decision-making in New York State with respect to removal of life support, it has to be the case that there is some extraordinary burden to the patient in addition to them having either a terminal illness or being in a coma-like state. So we have certain criteria, which you highlighted as proportionality, and I would even argue that it should be, in some sense, related to the therapy at hand, right? It seems to me that in this case it had nothing to do with the pacemaker being troublesome or unwanted per se, but rather a means to an end of not having to face a future life that might include developing dementia.
That's a great point. I think that's a great point. And New York State law, just to repeat what Dr. Blinderman says, when the patient perceives that the burden of continued existence with this device, whatever it should be, outweighs any clinical benefit. Well, the burden here was that I may go down the road, in the future. Right now, the person's not being burdened at all by the pacemaker, and it's mostly the emotional distress that the patient's feeling about what might happen in the future. So withholding versus withdrawing life-sustaining treatment. Let me ask you folks, do you think there's a difference between making somebody do not resuscitate, DNR, which is withholding an attempt to resuscitation, and a patient who's already on a ventilator taking the tube out and withdrawing a life support? Do you think there's any ethical difference between making somebody DNR, withholding versus withdrawing? Those who think that there is no difference between withholding and withdrawing, raise your hand. You're not graded on this. Okay. 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 And though
There's no legal difference.
no. Okay. Well, legal. Okay. There is no legal difference. Okay. But those I'm talking about, I didn't say legal. I didn't put an adjective. And those who feel there is a difference between making DNR, yeah, I think there's a slight plurality of the there is a difference. If I add my vote to that, it would make it definite. So anyway, but the truth is the consensus in bioethics is that there is no moral difference between withholding and withdrawing. That's the party line. That's the party line. However, withdrawing life-sustaining treatment is an act of commission as opposed to withholding life-sustaining was an act of omission. And consequently, withdrawing life-sustaining treatment is frequently perceived to have direct causation in a patient's death. For many patients, for many family members, for many clinicians, withdrawal of life-sustaining treatment carries a greater psychological and for some ethical burden. So I'm just telling you how people feel. I feel differently personally. Making somebody DNR when it's appropriate is not a big deal. Taking somebody off a ventilator is a bigger deal. It is a big, but I do it. I would advocate it in appropriate cases. And it certainly affects the gut more, I think, when you're doing that. Now, proportionality, which we refer to, the ethical condition of proportionality or perceived burden should be met in cases of withdrawing life-sustaining treatment. In all the U.S. cases, interestingly, whenever it was challenged, all the U.S. cases that led to court decisions allowing removal of life-sustaining treatment, the burdens of the therapy or the patient's suffering were quite obvious. So whenever this goes to court as to whether or not to remove life support, and the court has ruled that it should be done, the suffering was quite, I don't think that if this went to court, that the judge would have said the suffering is so obvious, turn off the pacemaker. I really don't think so. And that's this whole issue of proportionality. Is emotionally or existential suffering alone grounds for carrying out a patient's request to remove life support? So that's the question in this patient of the 90-year-old lady that I have postulated. Who has the last word on the severity of emotional and existential suffering? Now, I know that there are people who will say, Dr. Prager, you are a paternalistic, old-fashioned doctor. Goodbye, retire, we don't need your thoughts. Today, autonomy is king. This is the way. You have no right to tell me whether my existential suffering is great enough so that you should turn it off. I have the right, and I want you to carry out that right. I would disagree with them respectfully. I would argue that there is a huge moral issue involved, that I am the agent of their wish. I am not just a technician. I'm somebody who will have it, and I have to feel that this is ethically correct. And I don't believe in absolute autonomy. People who don't believe in, who think physician-assisted suicide is ethically wrong, do not believe that patients should have the last word, that there is a limit to patient autonomy. Those who feel that assisted suicide in appropriate circumstances is correct feel that autonomy does trump. So this is a legitimate disagreement. The future. As baby boomers age, we will have a tidal wave of elderly patients in the coming decades, a large percentage of whom will have dementia and heart disease. Is this patient the harbinger of many more such patients who will request removal of life support in the early stages of dementia? And the conclusion of the case, you might want to know what happened to this patient. There was a near unanimous decision by our ethics committee that further exploration of this request was warranted and not to carry out the request. Treatment of possible underlying depression should be offered. Reevaluate clinical condition. Desire to deactivate pacemaker would be revisited following appropriate psychiatric treatment, social work intervention. We were not going to do it. The patient was taken to another hospital in New York. He first tried voluntary stopping of eating and drinking. Patient could not tolerate it. The patient, this gentleman eventually sought care at another hospital. The palliative care, they felt at this other hospital the patient had absolute right to discontinue the pacemaker, even if this was to result in his death, excuse me. Ethics committee agreed. The patient was admitted to the palliative care unit. The pacemaker was turned off. The patient developed a slow rhythm with a rate in the 30s. Patient awoke following pacemaker deactivation after a dose of Ativan and asked, "Why am I still here? What is happening? I'm hungry." The patient developed symptoms of shortness of breath, was given morphine and Ativan, and he died a week later. So the patient's wish was carried out. Shows you a difference, by the way, our ethics committee, the other ethics committee felt like, what's your problem? This is a no-brainer. And we, with all due respect, we did not feel this was a no-brainer. Can a physician refuse to turn off a pacemaker? Physicians may not be compelled to carry out a medical act that is contrary to their values and violates their ethical principles. For example, a doctor who doesn't want to do an abortion is not forced to do so in this country, but should have an ethical obligation to refer to a doctor who would. In such a case, they should seek another physician. And so when confronted with patients who wish to remove life support, before considering any one of the options that are legal in the U.S., a physician must explore with the patient the factors that are leading to the request, see if there are any options for treatment which may palliate effectively the patient's symptoms, so the request for withholding or withdrawing might be retracted. Psychiatric consultation should be sought in any such situation. Ethics consultation should be sought in any situation in which the clinicians are uncomfortable with a request for device deactivation. And if the clinician who is asked to deactivate a device has personal beliefs that prohibit him or her from carrying out the deactivation, conscientious objection, then the patient should be referred to another clinician. So this is a case, it's a very rich case, I think, in terms of all the ethical issues that it raised. I think, as I said, I think this is the harbinger. We will see more cases like this, and I thank you all for your attention. Thank you.
Before you all go, we want to again thank Dr. Prager. This was great. Just a few announcements. So we in the Master of Bioethics program, just FYI, we have a lot of videos for free of past talks. We welcome you to take a look at that. We also, just FYI, have courses, certificates, master's degrees, and a lot of people who work here at Columbia take advantage of their tuition credits to do that. So if you're interested, please reach out to us or look it up online. And again, thank you all for coming, and please join me again in thanking Dr. Prager.
Thank you.